pocket, and some level they pay out of the pocket. But the big bulk of it is really the villagers, the poor, just like pretty much like India, right? You got 60% of your population in the rural area. So how do the government actually reach out to them is that to create an insurance scheme to actually cover the villagers and to also track the quality. And they use the KPI. So they do have some key performance indicators that the hospitals need to follow to make sure that they provide a good quality of care. At the same time, how do the villagers access to the care is really that they build we call it the regional health information exchange, where they tie it from the province to the district, to the county, to the village. So this is very important. And then more importantly, they try to create a unique identifier, okay, which today they don't have. Even they do have an identifier, they have duplicate identifiers in the country. Right. Okay. Going back to my own country from Singapore, I think the government in Singapore had done pretty well. I think there are 3 parts in it. I think one part is that there is an area where the patient had to come out of the pocket, a certain percentage. But also a percentage also goes, that is being subsidized by the government, a high subsidy by the government, to make sure that even the poor are able to access to care. And then the thirdly is really, we call it a MediSave Medicare scheme, where whoever that works, a portion of your salary go into the Medicare and MediSave. And this is very important because this actually helps you when it comes to a rainy day where you need to hospitals, where you need to hospitalize, or you need to go and manage your chronic disease when you are old. So the government help you to pump in money if you do your saving in your MediSave. Yeah. So again, I think it's good to actually look at it. But I think more importantly, most of these countries are actually going through a 3 level. They have to rethink the care model. They also have to redesign the care system. And lastly, they have to reinvent the care team. I think this will be very important to move forward in any countries.
I know obviously as a standalone health insurer, you're thinking of claims function in-house. And as you go planning that out, so what are some of the more critical features, from a very operational sort of perspective that you expect to have in a claim system? Or what are the things that, you're thinking about doing new as you do that?
Okay. In terms of a standard features, what we have really looked at is that when you get a claim, you should have the basic information available of a customer, which is like what were the exclusions which are applied, and a standard validation whether the claim is valid or not, or whether the procedure was valid or not. Beyond that, what we, as far as Max Bupa as an organization is concerned, we have a claim processing team which is in-house. So we do not have TPA services being used for a claim processing. Now, the objective of getting the team in-house was that as we were using a standard platform, which is an integrated platform, what we have also done is we have done a codification for our diseases, which is like using an ICD-10. And even if we do not get those codifications from our provider's end, we have an internal mechanism of codifying it. And we call it as an ICD codification program, which we run it. Now, the objective of getting the codification done was that in future, we really want to move on to a preventive care, wherein we have the record available of an individual and we can guide an individual or we can minimize the hospital utilization, and that's what we call it as a utilization of a provider or a disease management. So that was one of the aspects why claims was handled in-house. We have the data available, we should move towards a preventive care. In addition, we wanted to extend ourselves onto a well-being as well. So the idea was that we have the information which is available, and how can a technology help us to make this information available to different people to improve their services, or to keep a control or a check on different individuals who are involved, whether it is a provider or an in-house team as well.
Okay, great. Ramon, I know you're evolving, Health Sprint services to offer some additional services, and part of that is really to assist a hospital at their end, maybe doing some of what Anjana was talking about, like proper coding, because, a lot of hospitals just can't do that. So what are those additional services that you're assisting at the hospital side to ensure that they're able to get the right information out, so all of the subsequent processes at the insurer side happen efficiently and quickly?
Yeah. Actually, we 20% of the transactions that go through in our network today from large and medium-sized hospitals. Typically, the hospital started with having a desk which was not a qualified help desk, whose knowledge of insurance was nothing except was just to fax the sheet which was provided to him by the consultant. So we moved over that we use technology as well as people and put processes in place in the hospital and run them and handhold them to see that to upgrade the desk. We have reached a stage where we could do a complete transaction and validation and sending it out in the system for the payer to clear it out. So it becomes, the whole process becomes fast. But we could upgrade ourselves as well, because we've got typically paramedical people and medical people manning most of the desks as a service, and we could upgrade ourselves to give the coding as well to the payer, and that would be probably a great value proposition both to the provider and the payer. So once it's coded on in the system, then the provider as well can use that data which is coming in, and the payer as well.
So see, on the from the star angle, like you have a set of panel providers. I'm not talking about the social schemes, about regular commercial insurance, and there's an empanelment process, and then a lot of people have package rates and everything, and you have to capture all of that. And like, what do you give the provider facility? Like, they can go online, they can fill out some forms which assist in empanelment, and they can do put up their information about their rates and everything. This is for your, not the regional schemes, for general insurance. Yeah.
Especially, as you rightly said, the challenge with the service provider is the package rates. Since we were the first initial standalone health insurance company, we have made the packages for the major segment, the major categories. We already made the segments. We have also divided the A class and B class towns. We have divided the towns. We have given the packages to all our service providers instead of taking the packages from the service providers and making them to accept it. The biggest plus point we had is we were the pioneers to start, and we were able to give the volumes to them in the retail also. So in fact, that was the first level, and we ensured the entire details of the hospital. When we started saying the categorization of the hospitals, we started collecting online, basically. Then we had our own team of every district for the entire pan-India to have a complete inspection of that same facilities availability, specialist and the equipments, and the kind of facility extended to the people. So we have standardized the packages, start from the room rent to the specialist charges, to what are the kind of procedures possible. We have already listed down, and we have made it. That was the first step we took, and we are now almost pan-India. We are able to have a control on the packages, which we have categorized.
Sanjay, on coming back to the role of technology in ICICI Lombard's interaction, there's various other things, on the CRM side, on renewal side, I get timely SMSs before my vehicle insurance is about to expire, generally about 2 weeks before, and then I keep on getting them regularly, which is good, because I don't want to be driving around without insurance. So, we've already discussed about, say, prior authorization and claim stuff, but just on the other services, and renewal is just one example, but outreach, post-claim outreach to get some feedback. There are various things you'd be doing. Can you tell us about some of those?
You're right, Alam. I think one of the most important things, beyond claims, is the fact that we need to keep, the insured population insured. And make them, whether it's for motor or health, motor because of the fact that you need to mandatorily have insurance. Also for health, because if you have a break in insurance, you have issues in getting coverage again. And so because of that fact, it's our bounden duty to make sure that the process of renewal becomes seamless. And the other ancillary services in making sure that we are able to connect to the customer, in a scale environment, is automated to a lot of extent. Of course, there is a need to bring in people and a lot of other interventions as and when required to check the quality of the interventions which we are doing. But usage of technology, usage of